Hello, everyone. Welcome to your online lecture for drugs that are going to be used to treat inflammation in the human body. We're going to break this lecture up into a two-part series. The first part of this series will be addressed here in this particular online lecture. We're going to be talking about the traditional anti-inflammatory medications that we as athletic trainers really can utilize in our athletic training clinic. They're certainly available over the counter, but then also as prescriptions. So today in this lecture, we're going to focus in on aspirin, ibuprofen, Aleve, and then our second part of this online series, we'll talk about corticosteroids, which are most often injected or taken orally to help with things like cancer, for example. And then we'll talk about counter irritants, so something that would be a topical, non-steroidal, anti-inflammatory drug. But today, let's focus in on the anti-inflammatory medications that we as athletic trainers would be able to administer in the clinical setting, the ones that we can actually house in our athletic training clinic under lock and key. I'm Dr. Cosby. Let's go ahead and get started. So let's go ahead and get started here on this slide. I love your textbook is actually pretty amazing. I don't think I realized how amazing it was until I started actually preparing for this particular class. One of the things that I love are the graphics that it gives you. It makes learning so easy. So I'm hoping that this is a image from your textbook that I will attempt to kind of speak over. But as you all know, cellular injury can happen from many different things, right? It can happen from a bacteria or a virus attaching to a cell in our body and then mutating and replicating that bacteria or that virus, right? And we talked about that in the antibiotics online lecture. But today, what we're really talking about from a cellular injury perspective is really physical injury, right? So let's say we have a patient who comes into our clinic and sprains their ankle, right? When they sprain their ankle, they're going to stretch tissue and that is going to cause cellular injury, right? And so when cellular injury occurs, whether that's a stretch or a strain or a complete tear or a contusion, whatever it might be, when cellular injury happens, and this is for the minor injuries to the more extreme injuries, regardless, the process is the same. It's just a matter of how much of the process is allowed to take place and cause inflammation, right? And so as we think about this, there are really three kind of parallel processes that really occur at the initial onset of the injury. Many of these we won't be able to see, but eventually it translates into inflammation, which makes it more visible to the human eye, or presents to us with a patient who says they have pain in the clinical setting, right? All right, so off that tangent and back to this slide, right? So we have cellular injury, right? We have this ankle sprain that walks into our clinic, and then we have these parallel processes that are occurring at the same time. First and foremost, if stop here and go watch the inflammatory response lecture if you have not done that, because this is almost a repeat with maybe some additional information. But please watch that inflammatory response lecture first prior to continuing on in this lecture if you haven't already. So on the left-hand side of this slide, what we're going to talk through is the first kind of thing that will occur. And so when we have cellular injury, we immediately have two different types of cells kind of being released and traveling to the injured site. First are our phagocytic cells. What does that mean? That means there are active cells, are cells that are going to be responsible for engulfing all of the dead cells that begin to die off as a result of cellular injury. They're going to eat those cells. They're going to remove them from the injured area so that new cells can begin to grow, right? Then we have something called non-phagocytic cells, which are mainly responsible for kind of the healing process, laying down the platelets, walling off the injury so that it can't spread, right? So we have very active cells, which are responsible for phagocytosis and cleaning up the area. Then we have our non-phagocytic cells, which are less active per se in actually cleaning up the injured area, but are responsible for restoring it, is what I would say. So your phagocytic cells, right, talked about this in that inflammatory response lecture. Really, there are two key kind of phagocytic cells. Your neutrophils are going to be one of them. Your macrophages are going to be the other, right? And if you recall, your neutrophils, where do they occur early on in the injury process, or do they present later in the injury process? Which one is it? Good. If you said early, you'd be correct. They occur or appear at about 6 to 12 hours post-injury, with your macrophages appearing about 12 to 24 hours after injuries, right? And these phagocytic cells, their major role is twofold. Number one, it's to clean up the debris in the injured area so that we can kind of stop triggering the inflammatory response, right? But then the other thing that they do is they also signal cytokine, right? And your cytokines, what do they do? Does anyone remember from that inflammatory lecture? They cause a wide range of effects in inflammation, but their major role is to serve as kind of a GPS. Right. And so when your cytokines are released, they kind of signal the neutrophils and the macrophages to come to the injured area. So they remember that process of what we're going to call as chemotaxis over here in a second. They're going to trigger the neutrophils and the macrophages to kind of move in the direction of the actual injury to get there to clean up the injured site. Right. So we have this phagocytic process going on. Right. Your eosinophils and your basophils are very similar in that they have phagocytic actions. One of the key things with the eosinophils in general is they're going to do something over here. They're going to inactivate the chemical mediators, and we'll talk about that in just a key second. Okay, your basophils we'll talk about on this side of the chart as well. So I just want to make sure I'm not skipping anything. You're like, hey Cosby, like you definitely deleted my slide by accident, but it's back. So you're not like, hey, Cosby, you just completely skipped over things, right? But your eosinophils, they're going to basically inactivate your chemical mediators, or at least reduce the number of chemical mediators circulating, which will be key for the amount of inflammation that we observe in our patient, right? So I'm going to erase all of my markings just so that you all can see, and I can repeat: cellular injury, parallel process. You have one process, two process, and then process three. In the first process over here on this left side, we have a very active phagocytic cell and a very inactive non-phagocytic cell, right? Your neutrophils and your macrophages are going to be relatively active. Neutrophils very early on, your macrophages later on in the healing process. But the key thing is they kind of trigger the release of your cytokines, and your cytokines, the GPS that kind of stimulates something that we call chemotaxis. Chemotaxis is the movement of kind of cells, white blood cells, red blood cells, platelets, etc., to the injured site. Your cytokines kind of light up and go, the injured site is right here, right? So they provide directionality in travel for your neutrophils, your microphils, your eosinophils, your platelets, etc., right? Your non-phagocytic cells, even though they're not very active in cleaning up, they restore the injured area by kind of attaching to the cell wall and kind of restoring it, right? So we have that one process all in all, right? So we have that one process. Then the next process that you can see here, I'm going to go to the right side of the slide. We have at the same time, what we have is the release of chemical mediators. Now, remember what I said about your eosinophils is that they're going to kind of inactivate some of those chemical mediators. But let's look at this. Your chemical mediators are most often going to be released by two different types of cells, your mast cells and your basophils, right? So we talked a little bit about basophils over in the phagocytic cells, but then they also play a major role in what is called storing your chemical mediators. So both your mast cells and your basophils will store your chemical mediators, and they do that through a unique process. They have these things called granules or pockets, right, where the chemical mediators can just be housed until we have a cellular injury. Once we have a cellular injury, then the body's natural response would then be to trigger the release either from the mast cells or the basophils of specific chemical mediators, right? Most importantly, it is key to understand that mast cells are, for the most part, naturally circulating and live in our connective tissue near blood vessels, right? So cellular injury most often is going to impact most of the blood vessels in the epidermis and dermis layer, right, or in the muscle. And so most often we're going to see our mast cells being triggered the most by a physical injury. But it's certainly, remember, we talked about something that could be circulating in the blood, such as a virus or a bacteria, which might then trigger your basophils to release your chemical mediators. All in all, both of these structures release 3 different types of chemical mediators: your histamines, your leukotrienes, and your prostaglandins. So your histamines are going to increase capillary blood flow. Another way to say that is increased vasodilation, right? They are also going to cause increased vascular permeability. In fact, all 3 of your chemical mediators are going to cause an increase in vascular permeability. So imagine a world where you have a cell that's perfect and you have your fluid inside of the cell, and we can maintain the balance between the fluid inside of the cell, called intracellular, and the fluid outside of the cell, called extracellular. Now, your tissue, right, is extracellular, so it lives outside of the cell. We can imagine a world where we have an injury and we have an increase in permeability. What that means is little holes start to develop in the cell, and what that means is we see more fluid going out of the cell than going into the cell, and so we see an increase in the amount of fluid in the joint that is presenting to us, so i.e. effusion and edema, right? So when something's more vascularly permeable, that means more fluid is capable of leaving the cell and entering into the tissue. And this can be a good thing and a bad thing. It's good because it's going to press on the nociceptors and cause pain. It's going to tell us we're hurt, and we're going to back away from that. But where it becomes deleterious is when there's too much fluid moving into the tissue and it starts to limit joint range of motion, or it starts to impact patient performance, right? So your histamine is going to increase capillary blood flow, which means we have more fluid moving through the capillaries, leaving the cell, right? It's going to increase vascular permeability. Your leukotrienes are very interesting to me. In addition to increasing vascular permeability, they do something called increased chemotaxis. And so what that means is they kind of facilitate the movement of some of these cells, phagocytic cells, on the left-hand side of the chart. So they're going to facilitate movement of the neutrophils, of the macrophages, of the platelets to the actual injured site. That's what chemotaxis essentially means. And the other thing that they do, and we'll talk about it when we get to asthma, is if they're released, they actually trigger bronchoconstriction. So we're concerned, right? Because it's going to close the airway in an asthmatic patient. More to come in the asthma section. Last but not least, the other chemical mediator that's probably released in a higher number are going to be our prostaglandins. And on the next slide, we're going to talk about them very specifically. But for now, they also facilitate chemotaxis, increase vascular permeability. And the key differential between our prostaglandins, leukotrienes, and histamines is that our prostaglandins are going to stimulate a painful response. They are part of the reason that the patient experience or perceives pain. They're going to sensitize our nociceptors. They're going to attach to our nociceptors, and they're going to tell the body that I have an injury, I have a cellular injury, and that's going to manifest as physical pain, right? So that's the second process. And then the third parallel process that happens is kind of activation of our plasma protein synthesis systems. So there are 3. All of these kind of work in a cyclical fashion. In other words, one system will impact another system, which will impact another system, so forth and so on. So we have to figure out how we stop this cyclical pattern from happening. And in therapeutic modalities, you'll go deeply into this. But one of the things that we see in the protein systems is we have the kinin system. In particular, we have bradykinin. Bradykinin is very similar to prostaglandin in that it is going to heighten the painful response. It's going to lower the pain threshold. Therefore, we will perceive more pain than is probably present, right? So that bradykinin, those prostaglandins, are going to trigger or make those nociceptors more sensitive to pain. And we love that, like I said, right? Because then it tells us to withdraw from the particular sport. So we can blame our kinin system and our prostaglandins for patients who actually come in and see us because they have pain, right? So when our kinin system is triggered, it also triggers our blood clotting system. And blood clotting is extremely important in injury healing, right? We want a new blood clot to form. And that kind of has to do with platelet synthesis, right? So your platelets and your red blood cells are going to migrate to the injured site, and they're going to create a blood plug and allow that area to heal. It's going to wall off the injury and allow that injury to heal itself. And then last but not least, we have the complement system, which we talked a lot about over here in the chemical mediator section. Your complement system is truly just responsible for triggering the release of those chemical mediators. And those chemical mediators are here, the histamines, the leukotrienes, and the prostaglandins. So we have to back up a little tiny bit, right? We had the large overview of the kind of 3 different pathways that kind of create inflammation within the body. And so what I really want to do is focus in on what we know as the arachidonic pathway. It's an extremely important concept because it's where most anti-inflammatory drugs will exert their effect. And so it becomes important to kind of just spend a little bit of time here. So essentially what we see in the body is we have a cell membrane. Usually that cell membrane gets disrupted because we have, I'll write it in there, cellular injury, right? So we have this cellular injury, and then remember we talked about those 3 kind of parallel process: phagocytic, non-phagocytic. We have chemical mediators being released, and then we have these protein systems that are also working. All of this really leads to increased vascular permeability, leakage out into the extrastitial space, right? It leads to increased perception to pain. So we get inflammation and we get pain, right? But how does that process actually start, and kind of how does it work, and what is another kind of subsystem within that system, right? And this system is called the arachidonic acid pathway. And it's extremely important. So what we know about cells is that arachidonic acid kind of binds to the phospholipid membrane, right? And then eventually with cellular injury, it's going to trigger the release of this enzyme here called phospholipase. And what phospholipase does is it attaches to that same kind of phospholipid membrane and triggers the release of arachidonic acid. So it becomes kind of this kind of, I don't know what you would call it, a free floating, how does that sound? Free floating unsaturated fatty acid, right? So it becomes free floating. And as it's free floating, it then kind of breaks down into 2 key kind of metabolites. The first metabolite is known as COX. That is short for cyclooxygenase. And then the second metabolite is going to be lipoxygenase. So we have these 2 key metabolites, and they become way important. So we'll talk about the lipoxygenase pathway first because it isn't the focus of this particular online lecture. We'll spend more time on lipoxygenase when we actually start to talk about asthma. But remember your leukotrienes, that's what these are. Your leukotrienes are extremely important, right? They increase vascular permeability, they increase chemotaxis, so they encourage kind of movement of your phagocytes, your phagocytic cells to the area, your platelet cells to the area. But then in addition to that, your leukotrienes also cause bronchoconstriction, right? And so this is going to be key as we're talking about asthmatic patients and drugs that will be used to kind of target your leukotrienes to reduce the amount of bronchoconstriction that's associated with an asthma attack, right? So we have that. But what we're really going to focus in on is the COX pathway. So your cyclooxygenase, some interesting things about it, as we can see here. We have our thromboxane. Our thromboxane, say that twice, is responsible for platelet aggregation and kind of vasoconstriction, right? Then next, what we have is PGI2, also known as prostacyclin. PGI2 causes platelet inhibition and then vasodilation. And interestingly enough, it also kind of creates a mucus to coat our gastric region. And this will become key when we talk about anti-inflammatory side effects in just a second. But as you can tell, just between PGI2 and your thromboxanes, there's a little bit of a homeostatic relationship that has to exist between the two. In other words, we have to have some sort of balance between the two, because what do you see that they both control? Someone tell me. Great. If you said platelet, either aggregation or inhibition, right? One of those has to shut off at some point in time. So we can see how if we have compromise to our thromboxanes, right? Or to our ability to inhibit platelet aggregation, then we could have overproliferation of platelets or not enough platelets, and our patient can bleed out. So that's one unique thing, right? We can see that in that pathway. In addition to that, this is probably pretty general, but what I'm thinking about here is your your PGE. It's going to increase edema, which we talked about. It's a prostaglandin. It's going to increase vascular permeability. Fluid's going to leave the cell and move into the extrastitial space and cause swelling there. But then we also know that prostaglandins in general kind of trigger the release of bradykinins, lower the threshold receptors of your nociceptors, and cause more pain, right? So we can see we really want to target COX, right? The cyclooxygenase pathway. We see it's responsible for increasing edema. It's responsible for increasing pain. But one of the key things that we want to be careful of is when we inhibit this pathway, a few things happen. We lose the ability, right, to protect our gastric region, for example. So anytime we treat someone with an anti-inflammatory medication, we have to say, does the good outweigh the negative consequences as we're starting to treat patients with anti-inflammatory medications? So we talked about the COX pathway, right? So if I go back, we talked about this pathway here and we said, okay, this is the COX pathway. The COX pathway really has kind of 3 branches or 3 derivatives or 3 what we call our chemical mediators or eicosanoids. Those are just the prostaglandins in general, your prostacyclin or your prostaglandin I2 and your thromboxane, right? And so then as we move back here, we're going to spend a little bit more time talking about the metabolites of your cyclooxygenase. Interestingly enough, the COX can be broken down into 2 key metabolites, COX-1 and COX-2, or cyclooxygenase 1, cyclooxygenase 2. COX-1 is our housekeeping cyclooxygenase. So it's already free circulating in the blood. It's produced by the body naturally. Your COX-2 is most often what's induced by your cellular injury. So it's triggered after a cellular injury, right? The body releases COX-2. Now, what do we know about your COX-1? Your COX-1 is very constitutive. What that means is its major role is all of our natural body housekeeping functions. So mucosal protection, for example, it's going to balance your kidney and your renal blood flow, going to help with platelet aggregation and endothelial or cell wall healing, right? Now, your COX-2, on the other hand, is going to house our PGE2 and our PGI. And so we've talked a little bit about our PGEs and our PGIs, but let's just go back here, right? Our PGI, platelet inhibition, vasodilation, protects the gastric region, right? Increases edema and bradykinin. So a lot of the things that we see in the inflammatory phase are going to be attributed to the COX-2 pathway, not the COX-1 pathway. The scary thing about NSAIDs, though, mainly non-selective NSAIDs like our aspirins, our ibuprofens, and our Aleve, is that they're non-selective. So when we take an oral anti-inflammatory, most often it's going to inhibit both our COX-1 and our COX-2 pathways. And this can be a bad thing, right? Number one, we know that thromboxanes are responsible for platelet aggregation. So it's going to reduce the number of platelets kind of coming to the actual area. In addition to that, the number one sign and symptom or adverse effect associated with most oral anti-inflammatory medications, specifically NSAIDs, is GI issues, GI irritation issues. But that's because if you take a non-selective NSAID, it's going to also reduce the production of COX-1, which is majorly a housekeeping chemical mediator responsible for maintaining the pH and lining the mucosa of the stomach, right? So in a real world, what we would want is a drug that targets the COX-2 pathway, and we'll talk about those drugs in just a second. Now, as we think through this, remember we talked about arachidonic acid. We have a cellular injury. That cellular injury causes the release of phospholipase. Phospholipase causes arachidonic acid to unbind, and now it's free circulating, right? That arachidonic acid breaks down into what we call our eicosanoids or chemical mediators. Those 2 eicosanoids are cyclooxygenase or COX and lipooxygenase. So far, so good. Now, from this perspective, on this side of the chart, we're going to focus in on this most often in the asthma lecture. But remember, your lipooxygenase is going to produce leukotrienes, right? And leukotrienes, remember, we already talked about this. They're going to cause bronchoconstriction, increase mucus secretion. So leukotrienes are very important as we talk about patients who just can't or struggle to breathe, right? Where we're really going to focus in today is on the cyclooxygenase pathway, right? That cyclooxygenase, remember, it's kind of has two sub-metabolites, your COX-1, which is going to be your housekeeping. It's going to line the stomach and protect it, and is produced mostly in all tissues, right? Now, your COX-2 on the opposite end is induced by cellular injury. So this is what is triggered when we have a cellular injury, right? It's usually produced by your brain, female reproductive system. One of the reasons we have painful cramps, ladies, if you're listening, it's produced in the blood vessel walls and in the kidneys, right? So as we think through this, it becomes important to also think, okay, with these two metabolites, what things are produced from them, right? And we talked a lot about your prostaglandins, your thromboxane, which is a platelet aggregator, your prostacyclin, which is a platelet inhibitor, your prostaglandins in general, which increase capillary permeability and chemotaxis, right? So you have all of these metabolites being triggered or released as a result of the induction of mainly your COX-2 enzyme, right? Now, the question just becomes, how do our anti-inflammatory medications kind of work as we take them, right? And if I could draw an X in here, what we would then say is your NSAIDs literally block the COX pathway. So in other words, it's going to block right here. It's going to inhibit COX's ability to break down into prostaglandins, right? And for the most part, that's good, because when we reduce the number of prostaglandins, thromboxane circulating, then what we do is we decrease blood flow to the area, we decrease chemotaxis, we decrease the extent of the actual of the injury itself, right? Now, there are some things called COX-2 inhibitors, and what that would mean is, let me erase this. What that would mean is they would actually just work directly on your COX-2 enzyme, right? And if they work directly on the COX-2 enzyme, then we'll go back here, and what we'll say over time is that if we have just a true COX-2 inhibitor, we would be inhibiting all of the inflammatory response and not inhibiting the ability of our COX-1 to do what it normally does, right? Which is all of its housekeeping functions. And that's the ideal. The reality is none of the over-the-counter medications that we administer in the athletic training setting are COX-2 inhibitors. They're very non-specific, which means they're going to target, right? They're going to target both your COX-1 and your COX-2. So just keep that in mind. Hopefully you've learned some things. So let's talk about the effects on the inflammatory process. So in terms of anti-inflammatory medications, we know that inflammation is most often caused because there's a protective mechanism that's associated with that. Inflammation is not a bad thing. We know this. You know this. If you don't know it, you'll know it when you get into modalities as well. Inflammation is not a bad thing. It's going to trigger a lot of different responses. And I'm going to go back, right? I'm going to go back here, and I'm going to clear this slide because I think it's important that we go here. Inflammation is going to trigger a painful response, and we want that to happen. The release of prostaglandins, the triggering of the kinin system. We want our patient to have some pain, right? Because we want them to withdraw. Inflammation isn't a bad thing because it triggers the release of our phagocytic cells, which then begin the process of cleaning up the area. Inflammation isn't bad because it triggers our non-phagocytic cells, which trigger platelet aggregation and the walling off of injury, right? So we can go back to this slide and we can say, we want inflammation to happen. We don't want it in excess, right? And that's where we have to utilize NSAIDs to reduce the amount of inflammation that might be in the area, right? Inflammation most often is going to can be triggered by a lot of different things. I mentioned infection, allergy, but the big thing that we see in the field of athletic training is most often going to be physical trauma, right? Most of the response triggered by the inflammatory process is usually mediated by the release of chemical mediators. Prostaglandins probably the number one culprit, but because it triggers the bradykinin system and induces pain. But we also know that your histamines, your leukotrienes, for example. Those are also going to be responsible for increasing the inflammatory response that we see. So then that brings us to our NSAIDs, right? Our non-steroidal anti-inflammatory drugs and their effect on that arachidonic acid cycle. When we look back at that cycle, their major role is to block right here. So essentially what they're going to do is they're going to block that cyclooxygenase pathway, right? And that's important because that's the pathway that's responsible for producing prostaglandins. And we know that prostaglandins trigger a painful response, right? They also increase vascular permeability. So those are non-specific, non-steroidal anti-inflammatory drugs, right? Now, our COX-1, as I said, induces prostaglandin synthesis for a normal healthy body. So we have prostaglandin circulating. We just don't want it in excess, right? The prostaglandin that is circulating plays a major housekeeping role, which is to coat that stomach and to protect it from ulceration. So it's an extra layer and extra protection, right? Thromboxane causes platelet aggregation, and so it's going to be responsible for causing clots. So in some ways, we need that COX-1 pathway. We need it for healing, right, from the thromboxane. We need it to coat the stomach to protect it from the drugs that we're taking, right? The COX-2, however, is triggered by a cellular injury and is also involved in prostaglandin synthesis, but most often the part that it's involved with is the inflammatory part, right? This is the protective part up here in the COX-1. This is going to be the inflammatory part. So ideally what we want clinically is a drug that would just inhibit our COX-2, because then essentially we would reduce inflammation without reducing the other housekeeping effects of cyclooxygenase. I've said that 1,000 times already during this lecture. So one of the things that we have to consider is, yes, we're talking about non-steroidal anti-inflammatory drugs. So yes, these drugs will reduce inflammation, but secondarily, the drugs have maybe other indications and uses in the field of medicine, such as reducing pain, right? Reducing fever. And in some cases, like aspirin, they can be used for antiplatelet activity. Okay. Or as a blood thinner, for example. So let's talk about indications and uses, right? They're going to inhibit the inflammatory response or decrease the inflammation, or both, right? And where are they going to do that? Someone tell me. If it's a non-specific, right? You listening to me? Non-specific NSAID right here, right? If it's a very specific COX-2 inhibitor right here, right? And you all could now walk me through why we want to work here and preferably not here, right? Because this is going to be induced by that inflammatory response. This is all housekeeping, right? So we want to avoid reducing or inhibiting COX-1 where we can, if possible. All right. Next, there are tons of uses for our anti-inflammatory medications, but what I really wanted to focus in on is what are the uses in sports medicine, right? Clinically, chronically, we've seen it used in rheumatoid arthritis, fibromyalgia, for example. But where we see it most often, where we see that we administer oral non-steroidal anti-inflammatories are in inflammatory conditions like our bursitis, our tendinitis, our osteoarthritis, but certainly for fever and headache and dysmenorrhea, right? So pain with menstruation. You can also use it in acute injury. We'll talk about that. The jury's still out. And then post-surgery to reduce inflammation. So these are all of the key ways in which we as athletic trainers really aspire to use anti-inflammatory medications. In terms of our pharmacokinetics, it's absorbed in the stomach, which is why it's so important to not inhibit COX-1. We know about these drugs is they tend to cause ulcerations. And so if we reduce COX-1, we have less of a mucosal lining, increasing the risk for ulceration. The majority is absorbed in the small intestine. The great thing about our over-the-counter aspirins, Aleve, etc., is that most of them are bound to plasma proteins, making them easy to reach their intended target site, right? And then if it's oral, it's going to be distributed widely throughout the body. Most of it's going to be metabolized in the liver, and then excretion most often through the kidneys via urination, right? So we've got our pharmacokinetics. And then let's talk about classifications and key things that are extremely important for you as healthcare practitioners to understand. This is like we're on it, right? So we're going to talk about the half-life of a drug, the potency, prescription versus over-the-counter. Most NSAIDs are available over the counter, and then their prescription is just a more stronger, more potent version of that, right? So the three that I think are most important in the field of athletic training are going to be aspirin, ibuprofen, and naproxen, aka Aleve. And I've kind of highlighted maybe 4 variables that are important and drive clinical decision making for you. So example, the half-life of aspirin, is 25 to 30 minutes, right? The half-life of ibuprofen is an hour to 2.5 hours. The half-life of naproxen is 12 to 15 hours. What does that mean about how often you might need to take it? Great. Your aspirin is going to be removed a lot quicker, so you're going to have to take it more often, right? Your naproxen, well, it sits in the blood a little bit longer, so you don't have to take it as frequently or as often as you might, let's say, your aspirins and your ibuprofens. The other key thing to consider is when does it actually have an effect on a patient, right? So the onset of action for an aspirin is 30 minutes. For ibuprofen, it's 30 to 60, more on the 30 side. And then your naproxen sodium, an hour to an hour and a half. So let's say we have an athlete coming into our clinic who wants pain reduction quickly. Which of the 3 would you give them? Yeah, most of you are going to say aspirin. Most researchers would argue that ibuprofen is the standard, right? But let's say, for example, we're looking at duration of action now. So aspirin 3 to 6 hours, more on the 3. Ibuprofen 4 to 6 hours, more on the 4. Naproxen 4 to 7 hours, more on the 7. If we want the effects to be sustained for a longer period of time, which drug are you going to give your patient? Right? Most often you're going to give them that naproxen sodium. Okay. And then all of them are excreted via the urine, right? So your kidneys are going to be working overtime. But if we want something that to be quick, to reduce pain quickly, then you're going to move towards your aspirin, your ibuprofen. If you want something to last a lot longer with a longer half-life, then you're going to go with your naproxen and your Aleve, right? And so I hope this, just looking at this chart alone, changes the way that you think about drugs. If I want onset of action to be quick and rapid, I'm not going to give someone an Aleve before an event. I'm going to give them an ibuprofen, right? And maybe even a loading dose of the ibuprofen, just for consideration. Now, I've added in the most common drugs here. One of them is a prescription drug, and we're going to talk a little bit more specifically about it. So your aspirin, I'll do it this way. Your aspirin, over the counter or prescription, ibuprofen, over the counter or prescription, over the counter or prescription, and then your Celecoxib or Celebrex is going to be only by prescription, right? Now, this is a non-selective NSAID. Aspirin is a non-selective NSAID. Ibuprofen is a non-selective NSAID. Naproxen is a non-selective NSAID. And guess what Celebrex or Celecoxib is? Anybody? It's a COX-2 inhibitor. What does that mean? Someone bring it home for me. You got it, right? You're all probably scrolling back to maybe this slide right here, and you're going, Cosby, I see it, right? What do you see? You see that Celebrex, right, is going to work directly on COX-2. All of your other drugs are going to do what? They're going to block the entire pathway, which means they're going to reduce the release of COX-1 and COX-2, right? Your Celebrex is only going to target COX-2, and that is huge and it's key. So with that said, we don't always have Celebrex available to us, and it is the only COX-2 inhibitor currently. There used to be others, but then there were increased risk for like heart pathologies and adverse side effects. So the only COX-2 inhibitor on the market, anti-inflammatory right now, is Celecoxib or Celebrex. And then all we have available to us over the counter are truly our non-selective NSAIDs. And that's, we just have to do what we have to do, right? We just have to weigh the risk with the pros, right? So let's talk through aspirin first. 325 milligram doses most often. The recommendation for pain is 325 milligrams to 650 milligrams every 4 hours, making sure not to exceed the 4,000 milligrams. We're talking overdose. One of the Tylenol is probably the number one drug that patients overdose on, and then aspirin would be secondary to that in terms of over the counter. Keeping in mind that we talked a lot about loading doses, so this doesn't include the loading dose, but you probably want, if you're loading aspirin, then you probably want 650 to 925 milligrams, right? And then after that loading dose, you'll follow the 325 to 650 milligrams every 4 hours, right? Want to give loading doses where we can. You'll see that in most cases, the inflammatory dosing is a lot higher than the analgesic dosing. And so you'll, for inflammatory response, you want about 650 to 975 milligrams, and you actually don't need to do a loading dose with this. You want it every 4 to 6 hours. And again, not to exceed that 4,000 milligrams. Wherever you see not to exceed, it's to avoid overdosing of a particular over-the-counter drug. Next is ibuprofen, probably the most utilized over-the-counter drug for both analgesic and anti-inflammatory properties. We're not talking about pain. We'll get into pain eventually, but since we're here and we're living there, the recommended dose is about 400 milligrams every 4 to 6 hours for acute pain, right? An acute pathology, 600 to 800 milligrams. Now we're getting into prescription, right? Every 6 to 8 hours in chronic, like a rheumatoid arthritis, for example. And again, you do want to load the dose, particularly in this area, the acute phase, to 600 to 800 for the first dosing. Next is our inflammatory dose of ibuprofen. So you want anywhere from 400 to 800 milligrams. Just be careful if you're administering this in the clinical setting. Anything above 600 is considered prescription. So just be careful as you're giving those out. But you want about 400 to 800 milligrams every 6 to 8 hours for it to actually have an effect on the inflammation in your patient. And then Aleve, it depends on the Aleve that you get, but it can be 220 to 250 in terms of milligrams to 440 to 500 milligrams every 12 hours. So you can see the dosings a little bit different, and that's because it has a longer half-life, right? Probably a little bit more potent too. We can consider that as well. Or you can just do 250 if you don't do that 500 milligrams every 6 to 8 hours. So you pick and choose. I find that just going with a higher dosing and taking it less will improve patient practices, right? And that's really what it's all about. And with naproxen, believe it or not, the inflammatory dose is the same as the analgesic dose. So just follow the properties for each. Celebrex, remember, is an over-the-counter, is a prescription-based drug. Forgive me. And the big key thing here is it's a COX-2 inhibitor. This is great. That means there's less side effects associated with when patients take this actual drug. And so it's either just one pill, 200 milligrams daily, or it's 100 milligrams every 12 hours, which represents 200 milligrams if it's taken once. And then the same applies for the inflammatory dose as well. So you can see you have 4 medications, all with different dosing regimens. And this is extremely important for the exam. You have to understand this. You have to know just how much is appropriate for you to give, which is within the scope of our actual practice, right? So as we think about the different types of NSAIDs that we've addressed, there are 4 key NSAIDs that we've kind of addressed. We have to kind of consider how do we decide which type of drug to give the patient? First and foremost, the age of the patient is going to be huge. We're going to talk a lot about aspirin in just a little while, and aspirin is a big no-no for kids under the age of 14, right? Because it leads to something known as Ray's syndrome and can be life-threatening to your patient, right? The other thing to consider is, your non-selective NSAIDs are going to cause gastric irritation. So maybe elderly patients who already have issues with gastric mucosal lining, we wouldn't want to prescribe that. We want to give them a COX-2 inhibitor. The duration of the treatment, right, is going to be key. Do we give them OTC or do we give them a higher dose of prescription drug, which requires you to take it less orally, right? The time of onset, so if we were to go back 2 slides, right, the big thing is, do we want something that works really quickly or do we want something that takes a little bit longer but stays in our system, right? So those are all key things. Compliance, again, that's all about dosing. Which drug do they have to take the least amount of times per day that can just be as effective. And then, of course, we have to consider any drug interactions. We'll talk about maybe aspirin in just a second. And then the general health of the patient and the cost of the treatment, which most over-the-counter drugs, for the most part, are relatively priced and reasonable. Now, as we really specifically talk through aspirin, we know that it's going to have its impact when a patient takes it on the cyclooxygenase pathway. So arachidonic acid is allowed to be released or unbound from its cell, right? Phospholipase is still being released and allowing it to unbind. And then you still have lipooxygenase and leukotriene still being present, but where it typically will impact the arachidonic acid cycle is in the cyclooxygenase pathway. So it's going to inhibit the production of your prostaglandins, your prostacyclin, and your thromboxane, right? So we have this reduction in prostaglandin, and then the ideal is that it reduces inflammation and edema because we have less of those chemical mediators stimulating that inflammatory, painful process, right? Now, can be scary because, as I've mentioned multiple times, remember that COX-1 has housekeeping properties. So a lot of the inhibition of prostaglandin production, and now we're really concerned with GI upset, right? For example, bleeding if the pill is allowed to cause degradation in the actual stomach itself, right? The biggest adverse side effect taking aspirin certainly is GI irritation. It has been reported that anywhere from upwards of 40% of patients taking aspirin for a long term typically suffer from some sort of GI irritation. So the recommendation is to take it with a meal so that the meal can actually coat or protect the mucosal lining. There are other key concerns with the ingestion of aspirin. One of the things that we know about aspirin compared to ibuprofen, Aleve, and Celebrex is this. It actually has been used in the treatment for blood thinning, particularly for patients who need blood thinning that are having heart issues, right? One of the things that differs is aspirin is it permanently binds. Sheesh. And then you have your ibuprofen and your Aleve, which will reverse bind. So they will unbind to a platelet. So this aspirin absolutely is a key treatment, blood thinning treatment that can be utilized in patients, right? The biggest key concern is other interactions with drugs. So like warfarin, for example, which is another blood thinner as well. If a patient presents to you with tinnitus in the ear, then that might be a sign and symptom of aspirin toxicity. So you want to have the patient stop taking the aspirin right away. And then, as I alluded to, aspirin is not to be given in kids. The recommendation is actually Tylenol most often. And the reason for that is it can trigger what is called Ray's syndrome, which is a rare but very fatal acute illness that usually is associated with a viral infection or previous viral infection. So if you have teenagers that you're working with, do not give them aspirin. In fact, give them either ibuprofen, Aleve, and or have them prescribe Celebrex. That would be safest. One other interesting thing is patients who have asthma tend to be more sensitive to aspirin. So aspirin, as we've said, is a kind of cyclooxygenase pathway inhibitor, but there has been some research to suggest that aspirin can in some ways impact the lipooxygenase pathway, triggering leukotrienes and then causing bronchoconstriction. So we want to be very, very careful with the use of aspirins and patients who actually have asthma. And then in terms of side effects and adverse reactions, the biggest key thing is going to be your gastrointestinal side effects. It's a powerful antiplatelet, anticoagulant drug. It is not going to unbind from the platelet. Once it's there, it stays. So this is a good thing for most patients. But in patients who aren't really using it for antiplatelet, anticoagulant effects, then the recommendation is that a patient shouldn't use aspirin any more than 4 to 6 days. In other words, they might bleed and continue to bleed, right? One of the things that we see in patients who take aspirin long term is kidney damage, right? So other contraindications, and pregnant women are going to be on all of the lists that we really talk about because of the placental barrier. And then patients with peptic ulcer diseases, right, or GI bleeding should not take really any of these drugs. So then we're moving forward and we're going to talk about combination aspirin products. You can have buffered aspirin, and this is great. A buffered aspirin essentially is like something that it has like some sort of antacid, let's say, in it, right? And so then once it's broken down in the GI tract, that antacid will kind of balance out the pH and reduce the risk of pepsid ulcer, for example. You can also have what we call as a delayed release aspirin. Remember, it's coated with some type of gelatin, and so it bypasses the GI tract and goes into the small intestine where it's better able to be processed and absorbed there. And then you can have aspirin with caffeine, and we're going to talk about headaches and the treatment of migraines in particular, and the introduction of caffeine. Now we're talking about ibuprofen. Ibuprofen is one name. There are other names over the counter. Advil, Motrin, Nuprin are examples of those. So any four of these, the dosing regimen still applies. It is by far the most frequently used over-the-counter non-steroidal anti-inflammatory drug. It is available in 200 to 800 milligram tablets, but by prescription, though, 600 to 800 milligram tablets, and then you have over-the-counter in your 200 milligram tablets. But reality is we can do what? We can have a patient take 800 milligrams, and that becomes a prescription-based strength, right? So we have to be very careful when we're entering into those waters. Some great things about ibuprofen is it's absorbed relatively quick. So it will reach like peak plasma levels within 15 to 30 minutes of ingestion, which is great. So if you want something quick, then ibuprofen is going to be your go-to NSAID, which is why most people take it. So it has this rapid onset of action. The hard part is the effects just don't last very long. So they have to take it more often, right? Okay. Naproxen, also known as Aleve, is chemically similar to ibuprofen. However, it's a little bit more potent and has a longer half-life. So it isn't going to have as quick of an onset of action, but it will last a lot longer, making it probably a drug that's easier to take for most patients because they have to take it less over time, right? So whereas here we saw that peak plasma concentration levels were like 15 to 30 minutes, your peak plasma concentration levels aren't going to be for about 2 to 4 hours. So this isn't a drug that you want to give to someone who wants to go out and participate right away, right? Lean towards your ibuprofens or your Motrins, etc. Now, next we have celecoxib or Celebrex. This is the only COX-2 inhibitor. So this is the one that we really want to take, but not every patient is going to get this, right? And it's not available to us over the counter. So it's a COX-2 inhibitor, which means COX-1 is untouched. And so it can line the mucosa. It can do all of the things that it's supposed to do. It's in 200 milligram tablets. Peak plasma levels is 3 hours. Half-life is 11 hours. Problems for the most part are relatively low. The biggest thing is overprocessing or breaking down by the liver and excretion by the kidney. So sometimes you'll see a little bit of liver and kidney toxicity, especially if patients aren't taking it in the small doses that are actually recommended. So what are some of the side effects or adverse reactions? So this is research that I'm giving you from 1997. The research probably higher than that. 76,000 hospitals from NSAID effects, hospitalization from NSAID effects. So I don't know if I'm scaring you because this is a drug that we oftentimes give to patients, but this is huge. It's key, right? 8,000 deaths yearly from NSAID intoxication. So you know that NSAIDs in general, we're not talking aspirin. The side effects are very similar. GI bleeding is going to be number one because there's inhibition of COX-1, right? Nephrotoxicity or kidney disorders can definitely develop. The other thing that we worry about is if a patient has an aspirin intolerance, then they most often have an NSAID intolerance. So then you might have to move to your COX-2 inhibitor anyway. And then signs and symptoms of a patient who maybe has hypersensitivity to your ibuprofens would be like hives, rash, itching, maybe bronchospasm, for example. Contraindications, known allergies, pregnant women, of course. And then the key thing is going to be head injury, because it is an anticoagulant. Even though it will unbind, it can have anticoagulant properties. And with a head injury, we don't want to mix the two. So I think that makes sense, right? In acute inflammation, the part with acute inflammation is very similar. It's an anticoagulant. The other concern is, if I were to go back, 10 slides, one of the things that we said is, remember, in acute inflammation, we have our phagocytic and non-phagocytic, I'll do phagocytic, right? Properties, where we are going in to clean up the injury. We're going in to restore the injury. We're going to start laying down our fibroblast, etc. And so that will usually slow down that process, which may lead to slower healing times over time. So because of that anticoagulant property, and because it will in some ways inhibit the non-phagocytic and phagocytic roles, we want to avoid taking anti-inflammatory medications in the first 24 hours. Remember, your macrophages, your neutrophils, we want to avoid inhibiting those where we can. Effects on exercise. There really isn't much out there in the literature. The last thing that had been published was in 1992, which suggests that NSAIDs increase adenosine levels, which could be considered an ergogenic aid. But again, there was very little research to support that. The one thing that we know about ibuprofen and naproxen, and where we see it being utilized in clinical setting in a non-injury model, is that it has been reported to limit delayed onset muscle soreness. So if you were thinking about a patient who just did some type of eccentric exercise, then the use of ibuprofen and or naproxen most certainly could limit the pain associated with that, right? And then other things to consider, the age of the patient, right? So patients that are older than 60 are at increased risk for GI toxicity and peptic ulcers. And then again, for children, ibuprofen and Motrin are safer than aspirin, but the rule of thumb is just to stick with Tylenol in children. Duration of treatment. Long-term use, safety, cost must be balanced, right? And then dosing schedule. So those are all things to consider with any of these drugs, really. And then the time of onset, right? Ibuprofen is going to reach peak plasma levels sooner than your naproxen sodium or your Aleve. So those are things to consider as you do dosing for patients in the clinical setting. We also have to consider what other medications the patient is taking, the general health of the patient, and then the cost of the treatment. Again, Celebrex can be expensive, so you might have to lean or rely heavily on your over-the-counter medications. And then what are you going to tell your patient? I think this is a key thing, educating your patient about how to take medication, when to take medication, will improve patient compliance, number one, but then also will reduce the side effects, right? Take anti-inflammatory medications with meals. There could be potential adverse effects. So tinnitus, for example, let you know when these things are being experienced. Take the medication as prescribed. Good luck with convincing your athletes of that. And then just some general guidelines for you. NSAIDs have not been shown to restore normal tissue function, right? Following injury. So if that's the case, if it's not facilitating the healing process per se, do we need to introduce it as early? The answer is no, right? At least wait 24 hours to allow those macrophages to kind of move into the injured area. Really what you want to ask yourself when you give an NSAID is, do they actually have swelling, right? If they do, then the answer is we should be giving it at the anti-inflammatory dose, not the analgesic dose, right? Which is going to be a lot higher. NSAIDs are not banned by the United States Olympic Committee or the NCAA, so that's why we kind of see a little bit of overuse among collegiate level athletes. GI damage can occur. The sad part about GI damage is sometimes they don't have symptoms, right? So we want a 10-day regimen of NSAIDs, and then we want to consider something else if they just are not working, right? And then never take NSAIDs with alcohol. I don't think I need to say that, but it can increase the risk of developing some type of peptic ulcer. That includes the lecture for your NSAIDs. I hope this has been helpful.